Yeah, thank you everyone for giving us the opportunity to come speak to you about the Opal Community Service. So yeah, as Nari alluded to, ko Herman Song Toko Ingoa. I've been at Deloitte for the last year or so, but previously I've been in the Francis Health uh, uh, organization, and I've been seconded into the Mid-Central District over the last couple of years to work alongside Syed and the Healthy Aging and Rehabilitation team up in Mid-Central to deploy this service. I'll pass that over to Syed to give his intro and kick us off in the preso. Over to you, Syed.
Kia ora koutou. Yes, I'm Syed Zaman. I'm a geriatrician and head of geriatrics here at Palmerston North Hospital. So thank you very much for giving us the opportunity to share our experience of setting up the Older People's Assessment and Liaison Community Service, or OPALCS, which is less of a mouthful. Next slide, please. So I'm sure that everyone in the audience will know that a comprehensive service for older people comprises a number of components spanning hospital and community. We also know that many older people end up in hospital unnecessarily and have long stays in hospital away from home, which is suboptimal and potentially can cause harm. There are hospital-based services that are available, such as outpatient clinics, but travel distance can be a barrier, and often referrals are made late, leading to acute presentation. So up until recently, community support services that provide proactive and preventative care to older people with frailty were not available in Mid-Central. Next slide, please. So what is the Opal Community Service? So essentially it's a community-based, or they are a set of community-based transdisciplinary teams that deliver in-home assessment and care for older people with frailty across the Rohe. They also proactively case manage at-risk older people with frailty, with a priority focus on preventing and minimizing further deconditioning. The teams also signpost and navigate people to services that offer an alternative hospital admission. And importantly, the team also have an important role in education and training. They help to increase the competence of primary care and community to identify and manage frailty in the community. Next slide, please. So as I mentioned, the service is focused on preventative and proactive management of frailty. So it can provide balanced retraining and muscle strengthening to prevent falls. It provides home and mobility equipment to support independent living. It offers medication reviews to protect from the adverse effects of drugs and polypharmacy. And it also can offer support to older patients with anxiety and depression and patients who have behavioral and psychological symptoms of dementia. Next slide, please.
Cool. So this slide is really just showing the who's in the team. So it's really a transdisciplinary team of consisting of geriatricians, clinical nurse specialists. We've got allied health, so your occupational therapy, physio, social work, allied health assistants as well to support some of the delivery of the services. Syed, you're, I think on the screen, you're just a little bit blocked, and what we have on the top right here is also a kahapai kaumātua ora role, which we'll talk about later, but essentially a role to really connect with the Māori community to help us improve uptake of Māori patients into the service, and then also help the team support develop, more culturally appropriate ways of working with our kaumātua patients. And then also support linked assessor and older adult mental health nurse as well. So they're really working together as a, not a multidisciplinary, but actually a transdisciplinary team. So working together to provide everyone, especially in the allied health team, is able to do a little bit of, physio can do a little bit of the assessment for the social work and vice versa. So, Also, probably worth noting as well is the service interacts with our referrers, but yeah, as the we'll have one a key worker who manages the patient, and then drawing on the other members as needed to really avoid that multiple driveways up a patient's home. So who can refer to the service? As you can see, yeah, so we've got interfacing with the general practice teams. So quite a lot across the mid-central region, around 30 practices in total. We've got the NGO, Age Concern, Stroke Central, hospital-based internal referrals, and then also working closely, getting referrals from the iwi providers as well. So you can see a list of them down in the bottom left. Back over to you, Syed.
So the referral criteria are fairly straightforward. So the client must be living within the Mid-Central District, be over 65 or 55 for Māori and Pacifica, and obviously have frailty, so a Rockwood frailty score of at least 4, and one or more of things listed there. So change in function, cognitive decline, recurrent or unexplained falls, complex social issues. The client or the carer may have requested specialist assessment, or there might be potential for involvement of the older adult mental health team. The exclusion criteria listed there, I think, fairly straightforward. It's not an urgent care service. If the patient is end of life and known to palliative care, then we don't get involved. And if the primary need is for equipment only, then we don't accept the referral.
So probably two things to highlight in the service that touches on interacting with our Māori patients. So on the left-hand side, you see that we've got a bicultural comprehensive geriatric assessment. So with CGAs, that's already quite a multifaceted assessment, and that you're not just looking from a physical perspective, but you're also looking at social, mental, and other components. So what we've also added on is really working with our kaumātua on understanding who their whānau and whakapapa are, whānau community and social support, how much they're participating in Te Ao Māori, and then you can see some of the other areas around financial and social well-being, and not to miss out on also medical, physiological, and functional as well. And then a little bit more on the Kaya Hapai kaumātua roles to support our Māori clients, so these are essentially our connectors who work across both the iwi providers and the Opal service. So they're kind of like a hybrid role, working throughout the week, working across both from the iwi community space, and then also working closely with our Opal team, attending the MD weekly stand-ups to understand what patients are out there, connecting Māori Tau service, and then also supporting our clinical team to deliver culturally appropriate care and building that internal capability on tikanga Māori. So the 4 teams are now up and operational across Mid-Central District. So we started off implementing Horowhenua, the Horowhenua team first, Palmerston North in the middle of 2020, last year, and then finally the Tararua team later on in the year last year as well. So some of the learnings, early engagement with iwi is quite critical. Historically, the DHB hasn't had the best relationship with iwi providers, so it took a while to really, work with them to build the relationship, get the whanaungatanga, and really building, understanding what they need and designing the system that's, works across both Māori and non-Māori. Māori connector roles have made a really positive impact on engagement in kaumātua. We've got a little bit of data later on that I can talk through. It's important to continue working with the referrers, so your GPs, your NGOs, your iwi providers, to really keep them educated about what Opal's about, and being in front of mind on site really helps with, helping the referrers remember that Opal's here to support the community. And then I guess, yeah, from a Opal intervention perspective, it takes a while to actually build up that data to support the benefits. But, we're still in sort of early days, so we'll be watching some of the data as the service is running a bit longer. So wins, yep, talked about the 4 services now up and running. We are finding a better working relationship between Mid-Central and the iwi holder providers, along with the primary and community care. And yeah, so one of the data points that we've seen is that we've got quite a relatively higher rate of Māori clients within the Opal CS service compared to some of the existing elder health services. So yeah, we're seeing around 15% of patients being Māori, as opposed to 3% in some of the other community services, and just some feedback at the bottom right around from both referrers and patients. Just some of the data on probably highlighting the number of referrals have really ramped up over the last around 9 months. Majority of the referral sources coming still from general practice, internal referral, but we're seeing, starting to see some of the outside agency ramping up, and the Māori clients at 15% there. Back to you, Syed.
Right. So what does the future hold? So the teams are actually relatively small with respect to FTE. So each team, so we've got 4 teams, one in each locality, and so you're talking about 0.5 of a physio or an OT. So they're quite small with respect to FTE. If we could expand the FTE, that would allow us to take on a bigger caseload, so we could do more proactive and preventative work. But it also would allow us to introduce a home first component. So that would allow the teams to in-reach, to pull patients out of hospital, or indeed to see older people with frailty in the community quickly to prevent acute presentation to hospital. I think Herman mentioned that we developed our own assessment tool, but I think something for us to consider in the future is whether we should be adopting one of the InterRAI assessment tools. And also, as Herman alluded to earlier, there will be a need for us to analyze the data so that we can measure the effectiveness of the service. It is still very much in its infancy, and we are in the process of acquiring data and intend to analyze this in due course. Thank you for listening.
Okay, we have quite a bit of time for questions. Right, she's going to say you're going to have to use InterRAI. Who's got a speaker for her?
So you said that you don't use InterRAI data at the moment, but you have a support links assessor on the teams who do the InterRAI assessment. So are you then double handling by reassessing with the CGA?
I guess effectively we are. We did discuss prior to launching the teams whether we should adopt the InterRAI assessment tool, but there was resistance from other members of the team. There's a perception that it takes a long time to administer, taking the team members away from clinical work. We didn't resist. We just felt it was important to get the team up and running, get them used to working, get them accustomed to using the tool that they develop. But there's certainly a recurring item on our team meetings that we do need to consider when to adopt the InterRAI assessment tool.
Thank you.
Just maybe to add on to that as well. So as part of the design, when we're designing the service, we did test InterRAI as tool, because we're given that it's out there, why don't we use it? Then yeah, there was just a lot of clinical pushback from the teams around the time it takes to actually do the assessment, but then the sort of once you get back to your test and doing the various coding. I think we calculated it to be around 5 hours in total for just one new patient to conduct. So that ends up and then I guess furthermore is the cultural component to our assessment. So having some of the questioning around the whakapaha and the whānau and participation in the Te Maori. Yeah, it'd be really good in the future if we can incorporate some of those.
Which right of reply?
Follow-up question, how long does the CGA take?
Syed, over to you for that one.
Good question. Probably about an hour and a half.
We'll wait for your phone call.
Just
It'll
a bit of
come.
reinforcement from my experience of working with our rapid community access team. Just some experience from working in the community in Auckland for the rapid community assessment team, which is very much like this, but is morphed more into an acute service in terms of dealing with frail people who are often known to NASC already and have had an InterRAI, but something has happened to change their function, make them a little more confused or present. And what these people need is rapid at-home assessment, or can I emphasise the benefit of sometimes a rapid assessment in hospital to work out what's going on by the specialist team and then rapidly bringing them back to support them. And so we have a needs assessor within that team, but we get them sort of more stabilised, sorting out what's going on clinically, and then they do a reassessment, occasionally a new assessment, but most of these people are already known to do it. And it has to be reasonably quick and responsive. So that's your next steps, and that will really make a difference, I think. But it's hard work. Our service goes from about 8 till 10.
Do you want to set a comment in response, either of you?
No, thank you. I think are all very valid points, and it's certainly a route that we want to go down as soon as possible, the rapid response element.
And is there any online? Okay.
I'll be very quick. Two thoughts to take away. A contact assessment is a very good quick screener for looking at getting services in and finding the risks that are most important for the person and diagnosing what the ongoing risks are for more complex assessment. Secondly, if you're looking at the longer assessments where you've anecdotally heard they can take up to 5 hours, remember the model doesn't necessarily have to be one person doing them. One person can be lead and sign off, but you can have multidisciplinary team complete the InterRAI assessment, which takes away that 5-hour component because everybody's individually doing their piece in the InterRAI assessment. The fact that nobody's doing that doesn't mean it can't be done.
Thank you for that. We'll bear that in mind.
So from Sally, Heavenstar, how long does Opal team remain with these clients, and is there a role for the HCSS providers? They're the community home-based providers.
So in our operational policy, we state that the contact will be for between 6 to 8 weeks. And generally speaking, we adhere to that. There is some flexibility there. There are some that need a little bit longer, not many that need less. So flexibility, but roughly 6 to 8 weeks. At the moment, home and community support services don't play a part in the care that we deliver to clients, not for Opal CS, although they do support other parts of the service that were on the first slide, where there was, I don't know if you recall, but at one end of the spectrum, there was the post-acute community rehab. That essentially is rehab in the home following stroke and also following orthopedic admission. And our HCSS carers do support rehab in the home for that particular service, but not for Opal CS.
Thank you. I just, two questions quickly. I'm just curious as to what if there's a main reason for referral from GPs. Is there any particular kind of strong signal in that? And the second one was, you talk about measuring effectiveness. What does effectiveness look like in that context?
Good question. The main reasons for referral are, not unexpected. It's the recurrent falls, non-specific loss of function, and then cognitive decline and complex, social situations. Measurement of effectiveness. We really, thought long and hard about this, but what we're going to be looking at, we're looking at some impact on ED presentations. For those that present and then get admitted, we're looking at reduced length of stay for anyone that's been had input from Opal CS, because their complex issues have been dealt with, so there shouldn't be barriers to discharge. And then another aspect that we want to look at, I'm very happy to hear from the audience about how we can do this, is we would expect after input from Opal CS that there might be a delay to the admission to aged residential care, but we're struggling with how we could measure that. So very happy to hear if anyone has used that as a performance measure. And of course, the other way we're measuring effectiveness is from patient and whānau feedback.
Just quickly respond to your question about delayed care. I guess, okay, if you were using one of the InterRAI assessments, so say you were using a home care assessment, you could look at time from home care to long-term care and compare it with people that weren't referred to your service.
Okay. Thank you.
Yeah, thanks very much, everyone. And I know that we presenting a service that's not using InterRAI at an InterRAI conference is a bit, we're expecting some curly questions, but this is part of the thing, this is part of the work, right? So happy to connect with you guys to help us, leverage the good stuff that the InterRAI is able to do for our community. Thank you.
Thank you very